Good day and welcome to this webinar series hosted by Therapeutics on the clinical experience of bone regeneration with P15 peptide in degenerative spine and complex adult deformity. My name is Stuart Jefferson, International Sales and Marketing Director for Therapeutics, and I'll be your host for this webinar. On behalf of Therapeutics, I'd like to express our sincere thanks for taking the time to join this meeting, especially during this time of a global pandemic, when many of you will be dealing with the day-to-day challenges of COVID-19. Before we begin the meeting, a couple of housekeeping items. We'll be running from 3 computers today, and so we ask for your patience as we transition between the presentations. There will be an opportunity to ask questions, and this can be done by submitting these through the Q&A tab at the bottom of your Zoom meeting screen. Please can I ask that you ensure that all your microphones are muted and that your camera is off unless you are presenting. Finally, a copy of this meeting will be made available through your distributor representative, who you can contact from tomorrow, and they'll be able to forward you a link to this recording. We are joined today on this webinar by 2 surgeons, Mr. Chris Dare, consultant adult and pediatric spinal surgeon and clinical lead for spinal surgery, and Mr. Steve McGillian, consultant adult and pediatric surgeon. Both gentlemen operate at Southampton University NHS Trust in the United Kingdom. We are also joined by Dr. Scott Johnson, Senior Director of Clinical Education with Therapeutics, who will start today's webinar with an in-depth look at iFactor, peptide-enhanced bone graft. We hope you enjoy the meeting. Over to you, Scott.
Thank you very much, Stuart, and just like to extend also a very warm welcome to everybody attending the webinar. I really do appreciate your time, taking time from your busy schedule to attend and learn more about iFactor. So, as Stuart has just mentioned, I'll be taking some time just to quickly introduce the science, technology, and evidence that supports iFactor peptide-enhanced bone graft. When we think of bone grafts, we automatically think of iliac crest autograft, which has been the gold standard for graft materials for many, many years. But there are now many other options for bone graft materials available to surgeons. And these bone grafts have often waxed and waned in popularity over the years. And it's often very easy to think that they are all very similar, particularly in terms of their claims and marketing claims. But certainly it's not for sort of basing your cost on, basing your decision on cost alone. These products are not all the same, and as we'll begin to learn in the subsequent slides, certainly iFactor is something completely different compared to those other products that you may have encountered. So the majority of the products that are available on the market are simple osteoconductive scaffolds. The biological performance of these materials are influenced strongly by the chemistry, their porosity, and their physical structure. But with iFactor, we combine the osteoconductive scaffold with a bioactive peptide to form a composite bioactive bone graft. What makes iFactor really unique is this combination of a bioactive peptide combined with a calcium phosphate scaffold, which form this bioactive, biofidelic bone graft. What does the I in iFactor stand for? Well, the I in iFactor actually stands for integrin. P15 interacts directly with the cell surface integrins to elicit a biological response. And these integrins are cell surface receptors that are critical to bone homeostasis and bone repair. And in particular, they govern to a large extent the cell-to-cell interactions and also cell-to-collagen interactions. So P15 represents a small 15 amino acid sequence, which is typically found within type 1 human collagen. It represents the functional domain within type 1 collagen that's responsible for cellular attachment. And this sequence is naturally occurring within collagen, we simply synthesize the amino acid sequence synthetically and then bind that sequence directly onto the surface of the calcium phosphate carrier. So effectively, we're making the scaffold biofunctionalized by adding the peptide. So why use the collagen fragment? Well, type 1 collagen is extremely important as the main substrates for cells to bind to. We obviously, when we talk about type 1 collagen, we probably more recognize the collagen molecule as being a structural protein, just there to really provide structural strength. But it really goes much further beyond just a structural protein in terms of it supporting cells and enabling cells to understand the environment in which they are actually placed. So using collagen, and particularly the binding of cells to collagen, cells are able to understand the mechanical environment around them and also respond accordingly by changing the production of specific growth factors. So type 1 collagen is really important, particularly when we start considering the cascade of events that lead to bone formation, in particular the cellular attachment, cell migration, the proliferation, differentiation. All of those are really sort of triggered by that early cell binding. So type 1 collagen plays such a significant role in cellular interactions. Researchers have devoted their entire lives to sort of evaluating small portions of the type 1 collagen molecules and looking at the effects of those sites of the molecule on biological function of cells. So this is, as I say, someone's life's work. They've tried to characterize and summarize all of the interactions, the cellular interactions between different cell types with type 1 collagen. So this is called a collagen interactome. And you read it like you would a book. You read it from top to bottom and left to right, and it really encodes all of the different biological activities associated with cell binding in the different regions of collagen. One particular area is of specific interest, and that's in this central cell interaction domain. So this is the key binding site for which cells and how cells attach to type 1 collagen. And it's within this cell interaction domain where we find the P15 amino acid sequence. So the cell interaction domain is critical for cellular function, and it's one of the reasons that these sequences within this region have remained largely unchanged for millions of years. And that really highlights the biological importance of this particular region of the type 1 collagen molecule. And that's one reason why P15 in particular is such a powerful peptide sequence at binding cells. In fact, in some early experiments from the 1990s, when P15 was first discovered, researchers actually characterized the activity of P15 in terms of cell binding and found that it was 4,500 times more potent for cell binding compared to other cell binding peptides. So iFactor has a unique mechanism of action based upon the cell's natural high affinity for the specific P15 binding sites. So once attached via surface integrins, the cells receive chemical and mechanical stimuli which initiate a cascade of sort of growth factor production, including cytokines, bone morphogenic proteins, and that triggers the cell into upregulating its activity, and particularly for upregulating extracellular matrix production and also mineralization. So the activation of the cell is extremely important in terms of the local effects, and particularly on the cell, but those growth factors are also produced and influence other cells in the surrounding area. One thing to mention that's very important in terms of the mechanism of action is that those growth factors, particularly BMP2, are obviously produced in physiological concentrations. So unlike what you find with infuse or inductose, as they're called in Europe, you don't have a very large bolus of one particular protein there at the healing site influencing the cells. That often obviously causes adverse events. What we're dealing with here is a very natural response just to the cell binding to the P15. So the mechanism of action is actually very well understood, and the biological impact of P15 has been documented extensively in the literature. Studies have found that P15 not only increases the number of viable cells, leads to early differentiation, but also, and this is most significantly, it significantly reduces cell death. So once the cells are actually bind specifically to the P15 molecule, that significantly increases the chance of continued cell survival. So iFactor has a mechanism of action that's entirely based upon cells' high affinity for the P15 binding sites. And in cell culture experiments, the effects of P15 is very, very clear when compared to scaffolds that do not have P15 bound to the surface. So here you can see an image on the right-hand side with many more cells attached to the surface compared to the same scaffold material on the left-hand side, which does not have P15 attached to the surface. And in terms of quantifying those differences, then in the experiments, you can clearly see that there's a significantly greater number of cells bound to the P15 enhanced surfaces, and not only a greater number of cells, but also a higher number of surface area coverage on the P15 substrates. And that's extremely important, particularly if we start considering potential effects around infection as well. You want to get sort of cell surface confluence across the surface as quickly as possible so that you can minimize the risk associated with that, and also ensure that you can stimulate early bone growth as quickly as possible. P15 has also been shown to positively influence the early cellular development. And this is very important, particularly in the early stages of the repair process. P15 stimulates rapid development of the cytoskeletal organization within cells, and that enables the cells not only to increase their potential for migration and motility, but also enables the cells to reach out and to begin to communicate with other cells. And that's extremely important in terms of achieving a status of continual repair. And obviously, as the cells transition in phases through to osteocytes, it's key that they have the connections with other cells. So a more recent study published in 2020, researchers in the UK demonstrated that iFactor also yielded much higher levels of biological activity versus non-P15 containing surfaces. They used alkaline phosphatase as a specific marker for upregulation of bone-specific proteins, and found that there was a significant difference between those surfaces with P15 compared to those without. So this is the key question, really. Does all the great science that we have really translate into clinical efficacy? And before we sort of delve into some of the clinical studies that have been published, it's worthwhile mentioning, although iFactor is the first and only bone graft, peptide-enhanced bone graft on the market, it's been extensively used for more than 10 years across Europe. In over 100,000 cases as well. And that includes spine and also orthopedic indications. And we've also withstood the scrutiny of full FDA review, which was required in order for us to get our PMA approval. So not only generating evidence, but high quality evidence that is standing the highest possible regulatory scrutiny. The clinical evidence for iFactor includes multiple spine and orthopedic indications, and we're continually looking to build upon the evidence base in order to demonstrate the product's efficacy in different healing environments. So I'm going to quickly review some of the key outcomes from these studies in the subsequent slides. And I'm just going to start with probably one of our pivotal studies, which was our IDE study. So this is an FDA-controlled IDE study comparing iFactor directly with autograft. Single level ACDF, 319 patients enrolled across 24 sites in the US and also in Canada, and one-to-one randomization between the two groups. Main endpoints, primary endpoints, really efficacy, safety, 12 months, and also those were sort of a non-inferiority study plan. However, prospectively, we did define an overall success outcome measure. In terms of the results at 1 and 2 years, iFactor was found for each of the primary outcomes to be non-inferior in terms of those overall primary outcomes compared to autograft. However, in terms of the overall success outcome measure, and in order for a patient to be judged as having an overall success, then they needed to be successful in achieving all of the criteria listed here. So fusion success, NDI, neurological success, and safety success. And in that overall success evaluation, iFactor patients were significantly, found significant improvement over autograft. So fusion was typically observed to occur quicker in the iFactor group versus autograft, but speed is just one important factor when considering a successful fusion. I think the quality of the bone formation is also important, and this is something that we've also been reviewing with iFactor. So to date, clinical evaluation of bone grafts have mainly focused upon the time taken to achieve fusion, but I think it's also important for us to consider the quality of the bone formation as well. After all, one of the aims of bone grafts is really to leave behind nothing but healthy bone, which we will hope that is going to be mechanically stable and capable of bearing loads and supporting the continued success of the fusion. So these high-resolution CT images really demonstrate the transition from bone graft on the left-hand side, which is shown immediately, an immediate post-op where you can see a dense aggregation of iFactor within the graft window. Transitioning through at 3 months and then on to 6 months, you can clearly see the transition and development of the bone structure. So just in regard to some of the other studies that we've published, so the first study is by Mobbs, and this was a study from Australia. And in this study, they reviewed fusion and patient-reported outcomes from 110 ALIF patients. High fusion rates were obtained at 12 months, and these continue to improve to 24 months. And the authors here concluded that the outcomes were comparable to those results that were published for autograft and also BMP2. And that was also based upon their own anecdotal experience comparing iFactor to BMP2. This is an interesting prospective study. This was actually from Belgium, involving 40 patients treated with PLIF. One cage was filled with iFactor and the other cage was filled with autograft. So this is the same patient side-by-side fusion assessment. And within this study, iFactor yielded a much faster fusion than autograft at 6 and 12 months. And it was statistically superior at those 2 time points. It was only after 24 months that the fusion rate within the autograft cage actually caught up with the iFactor fusion rates. So very compelling data, same patient control, side-by-side assessment of fusion. This is probably one of the most recent studies for iFactor. This is an extremely challenging fusion environment. The patient group included elderly patients undergoing non-instrumented posterior fusion for lumbar-spinal stenosis. And patients were randomized either to iFactor or an allograft group. So in this situation, it's really a worst case in terms of bone formation. The patients have instability. There's no sort of mechanical structural support from the instrumentation. And in addition to that, in the elderly patient population, I believe the average age of the patients was 74 at the time of surgery. Then obviously they're in a position where their biology and capacity to regenerate new bone is also compromised. So the study compared the fusion rates and patient-reported outcomes at 12 months, and iFactor yielded more than 2 times higher fusion rates compared to the allograft group. So all of this science, all of this clinical evidence is available there, and it's packaged and is available to support our product portfolio. So the iFactor technology is available as a putty form, and also in some territories, a flexible strip called Flex FR, which is a fiber reinforced strip with pure silk fibers, which reinforces the composite bone graft. And then also more recently in territories, including Canada, we now have a brand new product available, iFactor Plus Matrix. This is a product with a different composition, with a higher concentration of the P15 peptide. So in terms of biological efficacy, that is significantly improved. And in addition to that, we are combining this composite material with a new matrix, which is composed of collagen fibers. And so that significantly improves as well the handling characteristics for the product. So I'm going to leave that there in terms of the science and a quick review of the science and the evidence. And I'm going to pass over to Mr. Dare and Mr. McGillian to give us the benefits of their clinical experience with iFactor.
Thank you, Scott, and also thanks to Stuart for the invite, and again a warm welcome to my colleagues around the world. I'm Chris Dare. I'm a consultant orthopaedic spinal surgeon at the University Hospital Southampton. My area of expertise is in adult and paediatric spinal deformity, as well as adult degenerative lumbar spine disease. So I'm just going to, this is where I work. This is University Hospital Southampton. It's in the south of England, so it's probably as far south as you can get. This is a level 1 trauma centre, and we have a sort of patient population as a tertiary referral centre for about 4 million patients. So I'm going to talk to you about my journey with iFactor and therapeutics, and why I fairly wholesale change in my practice from other bone substitutes to iFactor. Now, as the lead for the department, we periodically have a procurement process in the hospital, and as part of that procurement process, we'll talk about hardware as well as biologics. And my colleagues are 4 neurosurgeons who are primary spine surgeons, and 4 orthopedic surgeons who only do spines as well. And we had a range of products on the shelf, and I was keen to know from my colleagues about what they wanted to acquire moving forward. And that involved a conversation with them about what their indications were for using certain grafts. And when we looked on the shelves about what we had allograft, we had BMPs, and fillers. We had Kronos putty strips, Actifuse, Actifuse MIS, DBX, DBM, VTOS, all available. And when challenging my colleagues about why they used a particular product for a particular indication, it was clearly no consensus of opinion at all. The allograft was mainly a structural thing, and iliac crest bone graft harvesting was certainly on the decline and rarely performed. And so most people were using either autograft or allograft with a filler. And so, being as we didn't know which way we were going to turn, I thought it would be better if we go back to a bit of evidence-based medicine and see whether or not there was clear evidence about whether or not any of these products were doing what they said they would do, i.e. create a fusion. And Scott has very clearly identified some of the science behind P15, but this is a field which is rife with biological terminology, which I'm a surgeon. I'm not a biologist, and things like particle size, resorption, revascularization. These are bandied around by representatives trying to sell you a product. but I'm a surgeon, and I just want to know whether this actually does what it says it does. Does it evoke effusion? And particularly as a standalone product, a lot of these products are marketed as generating effusion, but as long as they're mixed with either bone marrow aspirate or autograft, but they generally need to be mixed with something, and then it gets a bit cloudy about whether or not it's the substance that they're mixed with or the substance itself that generates the fusion. So what I did is I set up a trade evening, and then certainly I would urge all of you, if you are involved in a procurement process, perhaps to entertain this as an idea. In that we invited all the product companies to come and give us a PowerPoint presentation on their product, presenting the basic science behind it and the clinical efficacy as well. And what became very clear from that trade evening was that the clinical studies that Scott has alluded to were very compelling, that the product on its own generates a very good fusion, as good, if not better than iliac crest bone graft. So that evidence was compelling to me and my colleagues, and we adopted this as our product of choice for our fusion material. So we'll talk a bit about the products and how we use it. So Scott has talked about the putty and the flex. Now the putty is a toothpaste consistency, very easy to mix with autograft, and very easy to use as a standalone graft. If mixing with autograft, the ratio should be somewhere between 30% iFactor to bone graft, up to a maximum of 50%. It should be mixed thoroughly, and if you're going to add blood, the blood should be left to stand for a while so that it clots before implanting the graft stop. Importantly, if you irrigate a wound at the end of an operation, please do this before implanting the graft, as this will tend to wash it out. The flex is a stiffer product, as Scott said. It's less flexible as it comes out of the packaging, but can be made more flexible by mixing with some blood if you wish to do so, but it can be put in dry as well. If you're using the strips, then the strip is placed in the lateral gutters, and then some autograft placed on top of it. And again, if you're irrigating the wound, do this before putting the graft in. So this is how I use it. Now I do quite a lot of anterior surgery, and there are a number of cages available to undertake anterior surgery. And this is one of the cages that I've used in the past. This is a B Braun cage with a screw augmented coated peak cage, but with a fairly large graft window. And so for those of you who want a cage with a large graft window, then flex is perfect for this. This is how flex comes out of the box. It's a little plastic container which you can put some blood into and leave it to stand. And as the flex softens, it can then be cut up into squares and impacted into the cage as you would do with autograft. This is a slightly different ADIF cage. You see there's not quite such a large graft window to pack flex into. And so for here, I just use standalone putty. As I say, it comes out like a toothpaste consistency. And I just fill the cage from both sides, wiping off any excess. Just compact it into the cage with a swab, then flip it over. And then fill the cage from the other side. And this takes somewhere between 5 and 7.5 cc's of iFactor. So again, just compressing it into the cage. clearing any excess off the rims so it's not implanted into the wrong place. And there we are, then we're ready to go. We're ready to implant. Now, I found that when I change my cages from a large graft window to a cage with a slightly smaller graft window, that and switching from flex to putty, is because the putty is a more liquid form, there is the potential for graft migration. I did see that on a few occasions where some of the graft had extruded between the implant and the end plate of the vertebral body. And so what I've done, what I now do is I get my my back team to warm up a bit of bone wax, and I pack a bone wax strip across the gap between the implant and the vertebral body above and below, and that seems to keep the any graft migration down to a tiny insignificant amount. There's been a global change in the use of interbody cages from PEEK to titanium, and more latterly the iteration of 3D printed titanium, which in the UK these were bought on stream with no graft window, so you can't actually pack any bone graft into these cages at all. And so, what in those cases, as most people did with PLIFs and TLIFs previously, you pack some bone graft into the disc space, and rather than just impact a 3D printed titanium cage behind that, I coat the surface in iFactor. The theory behind that is really to try and stimulate some bony on-growth. And kickstart the process of getting a stable fusion. When harvesting local bone graft, so this is all from lamina and facet joints, which are morselized, then I developed this technique to contain the graft in the lateral gutters. Here the graft has been mixed with iFactor, and then I turn that graft iFactor mix onto a piece of Surgicel, which is an oxidized cellulose polymer. So this is soluble or absorbable Surgicel, and I wrap the bone graft in this sort of burrito fashion, one for each side of the construct. And this, I think, just helps me contain the graft. So prior to this, all the metalwork would have been placed, and the wound would have been irrigated, and then I'm left with these two burritos to pop over the side of the rod into the lateral gutters, and then just ease that into position with a couple of cobs. I think there's a second cob following. There we go, and just ease that into the lateral gutter. And it's just keeping everything in a nice contained packet as we drop it over the rod. Initially with a cob, and then I use a thumb just to push it right down onto the transverse processes. There we go. And this is that case showing a post-operative radiograph, and you can see the containment of the graft in the Surgicel in the lateral gutters here. Now, some people may have some concerns about some local tissue reaction or foreign body reaction about leaving Surgicel in the wound. And my colleague, Mr. McGillen, came up with a technique for not putting that in, but I'll show you that in a second. This is how I use the graft for a TLIF with a graft window. So this is my scrub nurse mixing up the iFactor with the morselized bone graft. And I use a banana cage for my T-lifts with a graft with no titanium cage. So some of the iFactor and bone graft will be used to impact into the disc space. Some is packed into the cage, as you can see here. And the remainder will be wrapped in Surgicel and packed into the lateral gutters as well. So hopefully creating the largest opportunity for generating a fusion. And there we are, ready to go. And this is the Mr. McGillian technique. No, this is the Mr. McGillian technique. Sorry. So again, mixing the iFactor with the autograft. This time we're not going to wrap it in Surgicel, but this is a syringe with the end cut off, and just gathering the graft up in the end of the syringe and creating a bone graft iFactor plug, essentially. And it's quite easy just to slip the tip of this syringe over the rod into the lateral gutters and extruding it into place. And again, that contains the graft very well. So these are some of my cases. So this is a 68-year-old female. She's had previous 3 lumbar decompressive surgeries. I had back pain refractory to conservative treatment. I elected to go anteriorly in this case and did a 2-level ALIF. So this is her radiograph first day postoperatively. This is a CT scan at 4 months, showing that the graft is now being remodeled into bone across the disc spaces. Another ALIF. This is I've chosen to show you the ALIF cases today because this is as a standalone product. This is not mixed with iliac crest bone graft. It's not mixed with bone marrow aspirate. This is just standalone product. So it's a 51-year-old male, acute and chronic back pain, failed conservative treatment, virgin back, and had an L5S1 ALIF. We can see on the initial post-op radiograph, you can see the iFactor in the cage quite clearly. And this was a CT scan at 2 months. And here, this is one of the cases where I thought there was some graft migration anteriorly. And it's just anterior to the vertebral body. I think it's not gone anywhere of any concern. But again, evidence that the product itself is being substituted for bone across that disc space. This is the case I was just looking at yesterday, in fact, a year down the line. So this would be a challenging case for fusion with any product, but this is a lytic spondylolisthesis, reduced, not quite fully, but reduced with a spondylolisthesis reduction cage. This is the Globus Monument cage, and one of my concerns with this cage has always been that the graft window is relatively small compared to some of the other products on the market, but it's actually very good at restoring foraminal volume and pushing the L5 vertebral body back. So it works very well. But in this case, I haven't supplemented posterior fixation. I have just put iFactor into the cage. And on the CT scan, on the coronal cut, there's certainly good evidence of fusion a year later. Still, it's better on the right than the left, but certainly going in the right direction. Again, another ALIF, 45-year-old female, X-ray day 1, CT at 1 month, 5 months, and 12 months, with a good demonstration of evolution of the bony union across the disc space. And a 62-year-old degenerative spondylolisthesis with a level 4-5 ALIF, CT at 4 months, excellent bony union. So that's my journey, and I'll leave you with this thought of the day. I certainly urge you to read the clinical trials. It makes compelling evidence compared to its competitors. And on that note, I'll turn you over to my colleague, Mr. McGinnon, who's going to talk to you about some more the complex spectrum of the work that we do. Thank you for your attention.
Sorry, can I just check, Stuart, if my screen is sharing? I'm not sure it is at the minute.
Mr. McGinnon, yes, your screen is sharing. We just need you to go into slideshow mode.
Perfect. Is that good?
We can see it. That's great. Thank you.
Perfect. Lovely. Thank you very much, Stuart, for the introduction earlier. I'm Steve McGillion. I'm a colleague of Mr. Dares at University Hospital Southampton. And as Chris mentioned, really, I'm going to talk a little bit about our clinical experience of iFactor in complex adult deformity. So at the start of this evening or this afternoon's presentation, I guess, for those of you tuning in, Scott gave a very sort of eloquent overview of the basic science behind iFactor, and indeed the evidence in the literature. And a lot of this is obviously based around single and two-level fusions throughout the spine, principally in the cervical and lumbar regions. And Chris has demonstrated his experience and how we actually use the product in practice. And what I'd like to do is just give a run through of a number of cases with the degenerative spine in the complex adult deformity setting. As Chris mentioned, we are the regional centre for South Central England, providing services to the adult deformity population. So let's have a look through these. So really just to reiterate that obviously we do have a few different forms of the product available to us, and the choice of whether we use the putty or the Flex FR really depends on the approach that we're using for that particular individual. And for those of you that deal with adult spinal deformity, you're well aware that obviously there are a number of approaches available to us, both from an anterior, lateral, and indeed perhaps most commonly from a posterior approach. So with the anterior or lateral approaches, if you have a larger graft window, typically we will use the Flex FR. But if you're doing interbody cages from a posterior approach, so be it banana T-lift cages, oblique T-lifts or PLIFs, then the putty gives us another option. And often I find actually in these particular cases, we're using a combination of both products, depending on obviously what part of the spine you're dealing with. So for example, if you're doing an all posterior construct with interbody cages, we will use the autologous graft mixed with the putty, packed into the disc space, and again coat the cage with the putty, as Chris demonstrated in the previous slides and presentations. And again, if we're over the sort of longer constructs, if you've got a large posterior area of the lamina exposed in the spine, we will typically decorticate that and use the Flex FR to cover the surface area of the dorsal spine that's exposed. So just as I said, I'd like to run through some examples in this particular group of patients. So just starting off with a fairly typical degenerative mid-lumbar scoliosis, fairly typical of this sort of cohort of patients, really, where you have a mid-lumbar curve with marked degeneration above and below that. Some slight loss of coronal balance, but the main issue with these patients is obviously the sagittal profile, and as a consequence of this, they get quite significant back pain, progressive deformity, and often this also coincides with a degree of stenosis at a number of levels or a number of segments in the lumbar spine, and that stenosis can occur at a central, lateral recess or foraminal level. So you're trying to deal with a number of different problems here. And in this example, we've used an all posterior construct from the upper thoracic spine T2 down to the pelvis with a sound foundation with S2 AI screws. As you'll see, we have interbody cages at 4, 5, and 5, 1. And what I really want to draw your attention to is a slide in the middle here, which demonstrates that at 6 months post-operatively, we've got a nice sort of flowing mass of bone down across the, early bone formation, I should say, across the lateral gutters over the TPs. You'll also notice as well that we've got a double rod construct here across the lumbosacral junction. And what we often find with these patients is that they may have had 1 or 2 or more surgeries previously by the time they're referred to us. So often you're dealing with a large posterior laminectomy defect. And it's well recognized that if these constructs do fail because of a pseudoarthrosis, typically that will occur at the lumbosacral junction, most commonly at L5S1, but again at 4, 5 and other levels. So if there is a large defect, we'll often use a double rod construct. And again, similarly with pedicle subtraction osteotomies, that's another good indication to use a double rod configuration as well. This is another case. This is a lady. She actually presented to me in her, I think she was about 76 years of age actually at first presentation. And she had an L4-5 posterolateral fusion and decompression carried out at another center. And subsequent to this, developed a rather rapidly progressive deformity. Not only in terms of her spine, but when she walked into my consulting room, the most sort of striking abnormality with this lady wasn't necessarily her spine, it was actually her gait. And you'll notice on the plane radiograph on the left-hand side that the left hip here is just obscured out of view, really, and it just wants to highlight the point, really, of the importance of clinical examination, not only looking at the spine itself, but also looking at the lower limbs. And what you'll notice here on the lateral projection is that you can see there's pretty much complete destruction of the left-sided femoral head, and on clinical examination she had minimal range of movement here, and with very little pain actually, but quite significant limitation in the range of movement, and further radiographs of the pelvis demonstrated that she had actually avascular necrosis and complete collapse of the femoral head. The other thing, interestingly as well, in terms of her gait, is that she had quite marked valgus instability of the contralateral knee. So obviously before embarking on any surgery in this lady's spine, I think it was paramount that she had a solid foundation to build upon. So I sent her off to one of my arthroplastic colleagues. He carried out a primary hip replacement and a complex rotating hinge knee replacement within 3 months of each other, actually, and she made quite a speedy recovery from both procedures, and was very keen to get back into my consulting room again to discuss her options in terms of addressing her spinal issues, which had continued to progress. So again, in this sort of scenario, this is a lady, she's in her 76 years of age. She has a history of osteoporosis, which in itself obviously poses challenges in terms of the fixation. And again, she's had recent surgery within the last year, and I think prior to that had a further laminectomy done many years before that. So again, we're dealing with a relatively soft, relatively limited area for posterior grafting. So what I did, I carried out a T10 to pelvis instrumentation, again using a double rod configuration. This is the quad rod system from Globus, but a double rod configuration, hydroxy apatite coated screws. And again, the immediate post-operative X-ray, what I really want to draw your attention to is the iFactor Flex FR graft. So you can just sort of make out this sort of square graft area that's applied over the transverse processes. And this is an immediate post-operative period. At subsequent follow-up, this is 9 months later, what we can see is that graft has been largely resorbed. And actually what we're left with, again, is a nice sort of flowing mass of bone all the way down the transverse processes, nicely demonstrated here on both sides. And she continued to do very well following this. You'll note that there's some evidence of bone formation here, just around the posterior aspect of the metalwork as well. which again is from the lateral gutters, but a good solid evidence of bony fusion and plain radiographs at this stage. Now I think it's worthwhile at this point sort of highlighting that in the UK we don't routinely do CT follow-up in these patients. We only do further CT imaging if a patient presents with a rod breakage and a suspected pseudoarthrosis, and we're considering further revision surgery. Those patients again will be appropriately worked up, and a CT scan will be part of that imaging set as well. So this is a case of a proximal junctional failure that required a combined anterior and posterior reconstruction. So again, this was a lady with a good going history of osteoporosis for many years, on bone protection, but not at any sort of bone therapy in lines of teriparatide or anything along those lines. But she had this index procedure carried out at her local unit, and I think one of the reasons why it failed was not only the osteoporosis itself and the bone quality, but I think initially they'd failed to appreciate the extent of the true sagittal plane deformity on the original X-ray series, which I haven't included in these slides. But these are the slides at the point that she was referred to me, and what you can see here, particularly in the lateral projection, is that she has quite significant bone destruction here and collapse of these two adjacent vertebrae, with significant cutout of the screw, and again loss of her typical normal sagittal profile. And again on the AP imaging you can see that she's starting to develop a bit of a list towards the right hand side as well. So I carried out a 3-stage procedure under the same anesthetic. Initially went in posteriorly, removed the existing screw and rod construct, exchanged these and upsized the screws to a hydroxyapatite coated screw system. Initially carried out a wide decompression here because she had marked stenosis at this level, and then did a sloppy sort of hinge construct initially. Came around the front, lateral approach from the left-hand side, all subdiaphragmatic, and a 2-level vertebrectomy, and then did a reconstruction using the Nuvasive X-Core cage. Now, the benefit of this implant is that it has a rather narrow central core, but has a nice sort of wide peripherally bearing end plates that rest nicely on the ring apophysis of the vertebra above and below. And the benefit of this is that it's a modular system, but actually I tried to retain as much of her native bone as possible. And in jacking out the cage, then we were left with a bit of a defect. And again, you can sort of make out here the residual part of the vertebral bodies above and below their left. And then we packed the iFactor putty mixed with locally harvested graft from the initial stage in the posterior decompression, packed that in and around the cage itself, and then flipped her over again onto her front and attached the rods again with a double rod construct, because we got a large posterior defect here as a consequence of the decompression. So these are the initial post-operative radiographs. At 12 months post-operatively, what we can see here, and again on the magnified image on the middle and on the right, is that we've got a nice sort of flowing density of bone all the way across the defect, if you like, where she's had a 2-level resection. And again, there's a nice sort of bone surrounding the implant circumferentially in all areas. Although there has been a little bit of subsidence of the cage that you'll notice in the lateral projection, again, what you will see is that bone formation, that new bone formation, is almost uniform. Perhaps a little bit more work to be done at the top here, but we've got a nice uniform flowing mass of bone all the way down onto the end plates at the level below where there has been some settling, but a nice stable construct. And this lady did very well following this surgery year and continues to do so. So again, just to highlight the changes in the bone formation. So from the initial post-operative radiograph to the 1-year follow-up on the right, again, just to highlight, you can see the sort of defects in and around the bone and the cage here, but we can see how we've got that sort of nicely filled in over that time period. So pedicle subtraction osteotomy, I mentioned that earlier. It's well recognized that certainly with single rod constructs across a PSO, that there is quite a significant risk of pseudoarthrosis and failure of the construct. And I think one of Lenke's papers from a number of years ago presented figures in the region of 70% risk of failure, whereas moving to a double rod construct in that particular setting, that risk went down to about 17%. So it's still a challenging area to try and manage and to deal with. And as always, it's a bit of a race against time with the metalwork before it fails, before you actually have an established bony fusion. So I think that highlights the importance of a graft material. If you can achieve bone formation in a more rapid timescale before that metalwork fails, hopefully it gives a better chance of these type of constructs surviving and hopefully avoiding further revision surgery. Now, this was a lady in her mid-40s when she presented to my clinic, but some 10 years prior to that had a scoliosis correction for what was essentially an adolescent idiopathic curve that was neglected, so to speak, during her teenage years and had progressed into her adult life. So she underwent an upper thoracic to L5 fusion. And then, unfortunately, subsequent to that, she developed a distal junctional failure and a progressive kyphosis. And what you see on the lateral radiograph here is that over time, actually, she developed a fusion bridge here anteriorly between the body of L5 and S1. And again, on this radiograph, you can see how level the pelvis is here, if you like, in terms of the degree of retroversion. So the sacral slope itself is virtually horizontal. She's got quite marked pelvic retroversion. So she is compensating as much as she can, but still has quite a residual deformity as a consequence of that. Now, she had been told previously that there are no options open to her, but I did discuss the option of doing a pedicle subtraction osteotomy because, in essence, she had a fixed sagittal plane deformity. And this is the interruptive picture showing the PSO resection here posteriorly and then closing down the osteotomy defect itself to help restore a nice lordosis across those segments. Again, as I mentioned, you do end up with quite a large, obviously, bare area, so to speak, around the back. But this is where the flex FR or graft, whatever, if you choose to use the putty, either in the sort of burritos, as my colleague Chris described earlier, or indeed using the flex FR, which this is with locally harvested graft packed over the top. So the osteotomy level is in the middle here. We can see in the initial post-op radiographs that we've got a nice good dense mass of bone graft packed down either side, again with a double rod construct. Excuse me. And again, at the 6 months post-operatively, we can see actually there's some resorption of this graft material and perhaps some early signs of new bone formation in those lateral gutters. And if we follow things through to a year, again, we can see that over time you get further resorption of the graft and evidence of new bone formation. And again, this is also demonstrated on the lateral projection as well on the plane radiographs. So this was a lady, she was in her mid-50s actually. I carried out the index procedure myself here on the left, and perhaps a little bit of a learning point for me, but this was done approximately 5 years ago, the index procedure. So she had an upper thoracic spine construct down to the pelvis, a nice restoration of her sagittal alignment, and coronal images as well demonstrated the same. But I think my error in this case was that I'd somewhat ignored the fact that she had a rather healthy L5 S1 disc, and I think it just relies too much on a posterior construct if you don't have interbody support at 5.1 and again at 4.5. So our practice these days is really to use some form of interbody support, be it from a posterior approach, lateral or anterior, both of these levels really. So you do need to have a solid anterior column really, otherwise there is a high risk of developing a stress fracture through this area. So although she did develop initially a good posterolateral fusion mass and good fusions across the facets, she subsequently developed a stress fracture through this area. And as you can see, this resulted in fracture of the rods here, and again the typical sort of retroversion of the pelvis in an attempt to compensate for this. But she had a progressive sagittal plane deformity, and apart from just revising the posterior construct, I also felt it was sensible to go in from the front again to do an ALIF, help to restore the alignment, again using the putty, as Chris demonstrated in his slides earlier, as the graft of choice, if you like, in this particular cage, and then reattaching her rods at the back with a posterolateral graft area as well. So some 3 months post-operatively, she was complaining of a new, fairly non-specific pain type symptom that I wasn't really convinced there was anything major going on the plain x-rays. So I did do a CT scan just to check that everything was looking as it should. And this CT scan was carried out at 3 months post-operatively. And again, on the coronal images here, you can see there is evidence actually of good signs of early bone formation occurring across some of these windows, particularly laterally in the cage here. Still a little bit of work to be done in the middle. And again, you can see this is the sort of mid-sagittal section through this image as well, which again shows that there's some evidence of bone forming. It's only 3 months, so obviously early days yet. And again, coming back to what Chris alluded to earlier, there's perhaps a little bit of extrusion of the graft anteriorly, but this is still nicely contained actually. And again, in the evidence published to date from the studies that Dr. Johnson mentioned at the start of this evening, iFactor itself has been shown to have a relatively safe profile in terms of heterotopic ossification, to the extent that it will only actually produce bone if it's in the correct environment to do so. So HO is not really a recognized problem with this compared to some of the other biologics, particularly bone morphogenic protein. So as I say, that's just a run through of some of the cases that we deal with and how we have used the Flex FR and the putty in those clinical settings, and with certainly encouraging results really. The follow-up, as you can see from those slides, is largely limited to plain radiographs, but perhaps to some extent that is testament to the success of the graft material itself. And as I mentioned, we only do CT follow-up if it's clinically indicated, if there's evidence of failure of the rods and the construct, and we're concerned about a pseudoarthrosis that necessitates further revision surgery. And we're just actually about to embark on a retrospective review of our own case series to look at things in a slightly more critical fashion, really. So I look forward to having those results and sharing those with you in due course. But thank you very much for your attention.
Thank you very, very much, Mr. Dare, Mr. McGillian. I really appreciate those presentations. And we have obviously got the Q&A that is open. So I've had a couple of questions come in on the Q&A. Just one of the things, I was just wondering if you could possibly both comment for me on drain utilization. We have had a situation where a couple of surgeons have been using the putty product, and they have seen graft coming through the drain. What has your experience been with the utilization of drains, and have you seen this, and what tips could you give?
I'll take it on, Stuart. So I can understand some people's concerns about graft migration or graft up the drain, and I think that's related to two factors really. One is being meticulous about placing your graft and trying to contain your graft in the lateral gutters. Certainly, anteriorly I don't see it at all because I don't place a drain anteriorly. So this is all to do with posterior surgery. And the patient is prone, and there's a large potential space which fills with blood as you're closing the wound. So you can site the drain and then close the wound over the drain. And there's potential there for some washout of the graft if you close the wound that way. So to offset that, as you saw, I wrapped the graft in Surgicel, which is itself a hemostat, but absorbable, and that I think keeps the graft in where I place it. And the other thing I do to try and stop washout from post-operative hematoma whilst you're closing the wound is to close the wound under negative pressure. So I attach the wound drain to the suction, to the wall suction, and close the wound under negative pressure, so there isn't a large hematoma forming whilst the patient is still prone. And by doing it that way, I have seen very little or no graft extrusion at all through the drain.
Thank you. Okay, that's great. Yep, that's great. Thank you very, very much. Just wanting to see if there's any other questions that might come in at all. We're just watching the Q&A. So just a question that has come in. So can we say then that perhaps in the near future, with iFactor, we can go back and remove all hardware because the bone has formed a great fusion column?
Well, who knows? It does mean another operation for the patient.
So I would say the answer to that is no, actually.
Yes.
because even with when you're undertaking revision surgery, and I've been caught out a couple of times revising or extending constructs where there is a solid fusion to the pelvis. This is before the days of iFactor and therapeutics, and felt secure that I didn't need to replace, if I'm extending proximally and adding some screws in proximally, that I didn't really need to replace the screws in the distal construct. The problem is when you remove the screws, you create this stress riser. There's a void where the screws are, and then you create a long lever arm above that, and unfortunately the fusion mass does fail. Now that might upset Scott by saying that, because I know Scott or the company are very keen on looking at the quality of the bone graft. So it's not just about the fact that it forms a fusion, but it's about the remodeling and the quality of that graft afterwards. So yeah, it might change, and with that, when that evidence is available about how the graft matures, then so it's a possibility, but I wouldn't do it yet.
No, and again, I would
Thank you again.
There's again, one of the images that I did present, actually, that lady did have a good posterior fusion mass, but did develop a stress fracture through it and failure of the rods as well. So yeah, it can happen.
Great, thank you. One other question. What are the adverse effects you have experienced related to using iFactor? Have you had specifically any allergic reaction? And how have you managed this, if that has been the case?
Shall I take this one? I wouldn't say I've experienced any allergic reaction to iFactor, but as with any surgeon in practice, you will get deep infection, not as a consequence of the graft, I hasten to add, necessarily, but if you do get deep infection, I think the body's natural response to that is obviously for the wound to dehiss and for the body to try and expel those evil fluids, if you like, that are accumulating in there. So you will get some evidence of, for example, the putty maybe being displaced within that, but I think that's just more of a representation. If you've got a deep infection, which is more of a fluid-based collection, that putty has the potential to float around and be expelled in the dehiscence itself. But it's I wouldn't say it's in any way causative. It's just more of a reflection of a deep infection and a wound breakdown. But no, I haven't come across any adverse reactions as such.
And I would echo what Steve says there. I've only ever seen graft extrusion in wound infections. I've not seen it in healthy, healed wounds.
Thank you very much. Okay. Well, I think that's brought our questions to a close. What we're going to do now is going to end the webinar. And on behalf of Therapeutics, again, I would just like to thank Mr. Dare, Mr. McGillian, for your time. We are broadcasting from the UK, and it has gone past midnight. So I know that you're both very busy gentlemen, and we just really do thank you for being on this call later than usual, probably. As I have said, we will be making this recording available for review, and this can be accessed through your local distributor of iFactor. And we will be putting forward some further webinars in the near future. The next one that we're looking at is iFactor and its use in with spinal tumors. So look out for that over the next couple of weeks. That should be coming. And we will now end the webinar. The questions that have subsequently come in, we will make sure that we get to those via email. Thank you very much for your time and have a good evening.
Thank you. Good night.
Thank you.